Okay, I think it's time to begin. Welcome, everybody. We're very pleased to be here with you, and so welcome to our clinical conversations session for the month of February. My name's Barry Sorbet, and I'm the medical director for MCPAP, and we are so excited to have this topic today, which is entitled "Helping Adolescents Who Use Substances: A Guide for the Primary Care Provider." And I will be introducing our speakers and doing a little bit of housekeeping, and then we can just jump right in. So, just housekeeping wise, as everyone probably knows, we're on the fourth Tuesday of every month. And so our next session coming up in March will be on March 25th. And the title of that will be The Identification and Management of Pediatric Anxiety Disorders in Primary Care. That's going to be a presentation by Dr. Deepika Shaligram, who is one of our MCPAP child psychiatrists who works at Boston Children's. Housekeeping issues is CME. So we have CME, and as if you see your screen, there are instructions there, and it's offered through Mass General, and the code is displayed, and we'll put it in the chat, as well. And we always record our sessions, and they're available on the MCPAP website. So feel free to just listen without having to worry about taking notes. You'll be able to download the slides, and you can also tell your friends about this so that we can spread the word. We are going to, as always, try to cultivate some discussion and conversation. So feel free to enter questions in the chat or raise your hand, ask to be unmuted, and we'll be glad to give you a platform to ask your questions. If it turns out that someone asks a question in the chat that's kind of not really sort of relevant to what we're talking about at that particular moment, we'll save it a little bit, and I'll let people know, that we'll get to it. But we try to get to all questions, and we usually do. If there's any questions left over, we ask the speakers to respond via email. So here we are, Dr. Johnathan Schwab and Maria Alden are our speakers for today, and I will introduce both of them. The first being Maria Alden, who is a licensed independent clinical social worker who graduated from BU with her MSW in 2008, and she works at Boston Children's, the Division of Addiction Medicine, and has worked in a variety of community behavioral health programs for at-risk kids and at the Community Mental Health Center, and has done a variety of work, acute, longitudinal community mental health. So it has really, really wide experience. Since 2019, Maria has been providing substance use disorder evaluation and treatment for adolescents, young adults, and their families in collaboration with their primary care providers through a special program at PPOC called PC Plus. And she's also been providing individual and family counseling and facilitates groups as well for teenagers and young adults in the addiction medicine division. Our second presenter is Dr. Johnathan Schwab, who is an old ally, not old chronologically, but just he's been working with us for so many years and is a major champion for mental health integration in primary care. He has worked at Northampton area pediatrics for many years and has always had a special interest in working with teenagers and young adults, transitional age youth with substance use disorders. He's graduated of the University of Maryland School of Medicine and did his training and was the chief resident in pediatrics at Tufts. He is a board member of PPOC and Northampton area pediatrics. I will say, as a member of PPOC and kind of really an anchor, sort of this PC Plus program, which I'm sure we'll hear about. that Dr. Schwab has really been a pioneer in mental health integration, and his practice, Northampton Neuropediatrics, is really a very strong presence in Western Massachusetts, and they've done such a wonderful job in terms of building integrated behavioral health services within their practice. He's organized workshops for his patients and families, helping them understand the risks and harms associated with substance use disorders, and understand that treatment is available and that there is hope. So with that, I think I will hand it over to our wonderful speakers, and we'll kind of go from there.
All right, thank you, Barry. So I am going to just share my screen. And from the beginning. Okay. So thank you, everyone, for allowing John and I to join you today. So today we're going to, the title of our presentation is Helping Adolescents Who Use Substances, a Guide for the Primary Care Provider. Dr. Schwab and I are hoping to share with you an overview of how you can treat substance use in your primary care practices. The objectives for our presentation are to discuss the prevalence of adolescent substance use, to share how a collaborative care approach can support adolescents who use substances in your practice, and also to provide case examples of interventions that you can use in your practice. So first off, we're going to answer what's the real story related to adolescent substance use. I think that oftentimes we as providers or our very own patients make assumptions about how many young people are using substances, or what, who's using what. However, I think it's really important to look at the data, what the data is, to really know what we are looking at here. So the first off, we're going to talk about prevalence of substance use. From the 2022 Monitoring the Future study done by NIDA, the National Institute for Drug Abuse, they found that while experimentation with alcohol is relatively common, about 61% of 12th graders had reported that they had tried alcohol in their lifetime. Less than half of 12th graders were current or had used alcohol in the last 30 days. So the percentage was about 28.4%. With marijuana, I think some kids and adults think that all high schoolers use marijuana, but the truth is that less than half of seniors, of the 12th graders in this survey, had reported that they had ever tried marijuana, so 38.3%, and that only 20.2% had used in the last 30 days or were current users. We're concerned with substance use in adolescents because there's a lot of risks associated with it, including, in the leading causes of mortality amongst persons ages 15 to 24 years old in 2021. The top 3 leading causes of mortality, unintentional injuries, suicide, and assaults, are all linked to alcohol and other drug use. We also have found that, the correlates of substance use during adolescence have several different significant morbidities, including, injuries, intentional and unintentional injuries, emergency room visits, violence, arrest and incarceration, sexual assaults, unprotected intercourse, STIs, including HIV and school failure. The other piece that is also really critical to understand is the risk of developing a substance use disorder. The younger an individual is when they start using substances, the greater likelihood they are to develop a substance use disorder in their lifetime. There was a study done by Hinkson, Heron, and Winter, which found among individuals who had started drinking alcohol at 13 or younger, that they had a 47% chance of developing an alcohol use disorder in their lifetime, and that this risk significantly decreased if they started drinking alcohol at 21 or older. That the risk of developing a substance use disorder, if your first drink was at 21 or older, was only 9% compared to 47%. And so, that was obviously, kind of a critical piece to understand is just the risk of starting use so early. And a similar pattern was found with marijuana use, where, the age of first use of marijuana at 13 an individual had a 17% risk of developing a marijuana use disorder in their lifetime. And the risk significantly decreased when they were 20, if their first use was at 21 or older, where they had a 4% chance of developing a marijuana use disorder. Adolescents overall are developmentally vulnerable to developing substance use disorders and problems associated with substance use, which is, why we want to see how we can support them. So addressing substance use in primary care, we want to be able to address these issues in primary care because most adolescents are seen for routine care in primary care settings. So for adolescent substance use and treatment, in the SAMHSA study that was looking at data from results from a 2019 survey on drug use and health, found that 4.5% of adolescents ages 12 to 17 in that year had been diagnosed with a substance use disorder, meaning like that their problems with substance use were critical enough to affect like other domains of their life, or having some dependence on the substances. Of these individuals who had been diagnosed with a substance use disorder, only 8.3% of them received any treatment related to their substance use. So such a small number of the young people who had been diagnosed with a substance use disorder. We find that, healthcare is an opportunity to talk about substance use health risks. In some data that was collected by the Boston Children's Hospital Adolescent and Young Adult Medicine Clinic, they found some data collected from 14 to 18-year-olds, about 528 was the sample size, that 4 in 10 of these high school age patients had reported using alcohol in the last year. And 1 in 10 of them had reported binge drinking in the last 3 months. So engaging in more risky drinking behavior. There's a lot of support for integrated adolescent substance use care through integrated into primary care practice. Standard screening helps identify those at risks before use escalates. The early identification and intervention may prevent developments of substance use disorders and co-occurring disorders. And research shows a reduction in use as the result of brief intervention. So the conversations that you as a provider have with the young person that you're treating in your practice, even those conversations can have a huge impact. And then we've also found that receiving specialty care at a primary care practice is much less stigmatizing than going to another environment, going to a more substance use focused facility. I mean, we work with a lot of young adults. They prefer to be treated in their primary care practice versus going to a provider that focuses on addiction medicine only, that's for adults. It just feels very stigmatizing to them. In our program at Boston Children's Hospital, Primary Care Plus, which we refer to as the PC Plus program, we are part of the Division of Addiction Medicine, and we are a collaborative care program that provides outpatient treatment from experimentation to addiction. We provide virtual care for primary care patients who may have co-occurring substance use and behavioral health concerns. And the PC Plus social workers, like myself and my colleagues, serve as a collaborative member of the multidisciplinary primary care team. And we will regularly communicate with the primary care providers on, treating and supporting the young people who are using substances in their practice. And addiction medicine specialists are available to provide support and guidance to primary care providers through our program. So I'm going to bring this over to Dr. John Schwab, who can talk about how this works in practice through the collaborative care in practice and addressing substance use in primary care. So take it away, John.
Well, thank you. And thank you, Barry, for that kind introduction. I appreciate that. First, just a couple words about who I am. I am just a primary care provider. And in other words, I don't have any specialty training. I'm not an addiction medicine specialist, But I got interested in this because we had the opportunity of having somebody from the PC Plus program join our practice for about a year and teach us some of the things that I'll talk about today. But you don't need to have that kind of experience, because what I learned is that I can learn a lot more about this and then do things that I didn't think I could do before. And it's very much similar to just mental health in general. I mean, when I was in residency, I didn't have any training in how to treat anxiety and depression and ADHD even, really. And now that's a large percentage of my practice. And it's something like everything else. You find a need. In fact, Barry was very good in helping us through the MCPAP program of teaching us how to do this. And that's now it's really just routine medicine that we practice now through of that kind of mental health issues. And now that we have these substance use problems that our teens and our patients are using these substances, we had to find out how to help them. So that's really how I got interested in this. So what I'd like to do is to start about how do I identify patients who might need this kind of help. And there are two ways. The first way is through screening. We do screening at our well checkups. We use the S2BI. It's integrated within our EPIC, which is what our EMR is. Some people use the CRAFT screening techniques, but this is one way of identifying patients. Or you could just ask them during your well checkups, are you using substances? And they may or may not be honest with you, but at least they know who you are, and it's more likely they'll be honest with you than they might be with somebody who they don't know. The second way in which I find out that my patients need help is from phone calls. And a parent will call, and I would like to start with an example of this that happened just a few months ago. Next slide, please, Maria. So this is a true case. I got a phone call a few months ago from a mother of a 14-year-old who was actually cleaning his room. He had asked him to do that, and she found a vape device and cannabis in his room. And mom was very upset. She was very upset because not only did she find this indicating he was using this substance, but also over the past few months, his school deterioration he was deteriorating. His performance was really going downhill. He'd been a very good student. Now he was just getting by. He was spending a lot of time in his room by himself. She thought he was kind of talking to friends, and maybe he was, but it turns out his relationships with his friends had been actually severed to some degree. He was hanging out with other people instead. And she was really worried that he was depressed and sad, and she had no idea of what to do. And so she called me. Now, years ago, not sure what I would have done. I probably would have just referred him to somebody else because I didn't know how to take care of this. But now I have the knowledge and understanding of how to help. Next slide, please. So the first thing, this is an outline of what I do when I get a phone call such as that. I take a history. I use some education for the parent and the patient, and we come up with a treatment plan, which involves often urine testing. It often involves a referral to the PC Plus program, which you all can do. It might involve medications to help with either cravings or side effects from withdrawal, and then follow-up. So this is really, and also giving resources which are on the MCPAP website. So this is really no different than anything else that we do as primary care physicians. It's just in an area of something that you may not have been taught in residency or medical school. So next slide, please. So let me get down to some of the details. Here's some important points that for this patient, I had them come in. I usually schedule them at the end of the day when I can have much more time, because usually it's hard to fit into a same day. I don't know about you, but mine are 15 minutes, and this is not that kind of appointment that I can do in 15 minutes. I find out what are you getting out of this substance, in this case, cannabis. It's very common to have comorbidities. Those comorbidities often are anxiety, or depression, self-medicating. Sleep disorders are a big one. I find, in fact, I remember just not that long ago, a patient during the well checkup was asking for help with sleep, and he was said, so right now I'm using cannabis to help. And I talked to him about that, and then I actually said to him, would you be interested in getting some help from me for me to prescribe something? And he said, no, I don't want any drugs. It was an interesting kind of statement because he didn't view cannabis as a drug. And this is not uncommon. I think that now there are many people that feel that cannabis is something that's natural, it's grown, and it doesn't have the kind of side effects or problems that we know that in our patients, at least, who are adolescents, it can. It's also important in the history to try to find out about how they're using the products, because different types of products will have different concentrations, and it can give you an idea of just how much of THC they're actually obtaining. Then I also try to find out about what kind of problems this substance use could either be causing or certainly associated with. So we ask about problems with police or in school. As this patient had, he had both problems in school. His grades were dropping. And also ask about what parents are thinking about cannabis. It's actually, there's a survey that's done in our community yearly from high schoolers. And a large percentage of high schoolers say that who use cannabis say that they have the approval of their parents. So it's not uncommon that parents actually feel that this isn't a substance that's as concerning as some other substances that are out there. In this situation, the example I gave, that was certainly not the case, and that was helpful because the patient got the information, got the sense from the parent that this is not okay. I ask about, have they ever tried to quit? Because if they have and they were not successful, there may be reasons why, and things that I can do to help make it a more successful process. Part of the reason that people have trouble quitting is because of withdrawal symptoms and cravings that occur. Whenever you're addicted to a substance, can have these things, and I can help them with those sort of things. We know that cannabis is associated with schizophrenia and hallucinations and paranoia, and I ask about that to see to what degree they may have that kind of secondary effect. And then I do ask about how often are they using and when was the last time. And that has bearing on what the results from testing are. And I'll talk about that in a second. Next slide, please. So this is an acronym, the CRAFT. This is used for screening, but I use it actually just as a reminder to myself of what to ask. It's hard for me to remember what kind of questions are important. And by using this acronym, it helps me reminds me of what kind of questions I might want to ask my patients in this situation. So C is for cars. If you've ever been driving while under an influence or driven by somebody who's under the influence. R is for relaxation. Do you use this substance to relax, meaning that they're using it for a certain purpose? A is for alone. Those people who use substances alone are more likely to have a substance use disorder. F is for forgetful. This is when somebody is overusing certain substances, they may black out, for example, alcohol. F is for family and friends. Has anybody ever told you that you could have a problem? This raises my degree of concern when other people are noticing that there's a problem of use of substance. And then T is trouble, in terms of getting into trouble often with the law or with others. So these are just some ways of remembering what kinds of questions to ask your patients to get an understanding of the degree of difficulty this substance may be causing. Next slide, please. So once I got my information from this patient, I then wanted to educate them. And this is where there's a lot of misunderstanding, as I think you probably have already seen in some of your patients. How many times have you heard somebody say, well, I've done my own research, and that suggests that they found some areas where it suggests that these substances are not as concerning as we know they are. And first, we have to make sure that we're talking about substance use in our age population. I'm a pediatrician, so I'm talking about less than 22. And there's definitely good studies, good evidence and data showing, I think about them in 3 areas. One is increased mental health problems, which include, there's an association with anxiety, depression, as I mentioned, and psychotic disorders. There's also good studies showing that THC interferes with brain development. I think we all understand that, but I think there's still a lot of people who don't know about the way in which the brain develops and how THC, there are receptors in that THC actually binds to that can decrease one's ability to think, as well as decreasing intelligence. There are studies showing that there's a negative correlation between IQ and THC use. And then finally, there's studies that show that school problems have increased with those who use more of cannabis, and that career goals or aspirations are not obtained as easily in those who are using cannabis. So I try to educate people who are not sure that this substance is actually dangerous. Next slide, please. The next idea, once I've educated them, is to say, okay, let's come up with a plan. And one of the plans is to stop using the substance. Now, abstinence is always the best way of doing that, but there's often some resistance to just stopping completely. Part of that is they may be addicted, or they may still enjoy or get something that they think they need out of that substance. So you might use motivational interviewing to try to come up with some other ways of quitting that may not result in abstinence completely, such as using them only on the weekends or using it less total amounts during the week. And then the other thing is to consider drug testing. And this is, when I was in medical school and residency, we kind of poo-pooed drug testing or tried urine testing because we thought that was somehow not trusting the adolescent to be honest, and that by using drug testing, you were telling them that we don't trust you. Well, I think that it's come to fruition that that's actually not necessarily true, and that actually having hard data on whether they're using or not is very helpful in dictating where to go with the treatment plan. And I'll explain that in a second. Next slide, please. So urine testing is something that we do in our office, or we send it out, or it can also be done at home and sent to a lab. Quest Lab does this. Many of the local hospitals have this, and at Children's, of course, they have this too. But the question is, first of all, you decide where will the urine test be done. Again, I try to do it at home, and I think that I'm sorry, not at home, in our office. It's a little bit better to be done a fresh urine sample and to process it quickly, and to have it processed by a lab professional rather than a parent. But some parents want to do this at home, and that's fine if that's the only way to do it. When you do drug testing, you want to make sure that you understand what you're going to do with the test result. And so I always say that we have a good portal system. So I will say that I will contact both the parent and the adolescent or patient. And I say that I'll do it I do it by phone or I do it via the portal. And so if you have that plan ahead of time, you want to stick to it, of course. Next slide. So how do you use drug testing? Now, this is a protocol that I don't actually get into very often, but I can certainly refer them to the people like Maria at the PC Plus program. They can develop a plan of, well, first you say, okay, we're not going to have, you take away privileges until the first negative test. And then you can go out with friends, let's say, until 8 o'clock. And then you can see in the slide how you can, a week later, you do another test. And if it's still negative, you can go to out until 10. Or you increase the privileges the more negative tests you have. And then if you have a setback, you have to start this process over. as I said, I don't get into this too much, but certainly the therapists and the people, the mental health clinicians at PCP Plus can work you through that if they're referred there. One of the things to keep in mind is how long will a drug be in the system. So you do want to know a little bit more about that. Next slide. Do I have something on that? No, this is about collecting a sample, but let me get into a little bit of as cannabis is in our fat, once it's used, it is absorbed into fat cells, and so it's then excreted slowly. So you probably know that cannabis can actually be in your system, depending upon how much cannabis, how frequent, and how much you're using it. It could give you a positive urine test for several weeks. Nicotine can be detected in urine, and that is up to about a week. Alcohol is much quicker out of your system within a day or so. One of the things that we do, and you can do this through Quest, is you can actually get quantitative tests, and that will give you an idea of if the first week you have this much of cannabis, and then the next week it's less. You can assume that that could very well be that they're not using it anymore, but that they're just still a residual. So that sort of kind of a quantitative testing is very helpful. We often get a lot of questions about how do you collect the specimen, and there can be ways of getting around a urine specimen. But there are ways that is getting around it, meaning that the patient tries to fool you because they might have been using, and they actually, if they're actually don't want to have the urine tested. So the ways of doing that is if you do this at home, you can put dye in the toilet and run the water, or if they would agree to have a supervised test. It's best to have this done early in the morning, the first void in the morning. It's more concentrated that way. And it's also good to set up a plan that if a parent is concerned that there may be behaviors associated with a substance use, that they can have you do a urine test at that time. It doesn't have to be just weekly. But if that doesn't happen, we do recommend testing up to 8 to 12 weeks until you've had a consistent negative test. Next slide, please. So in summary, what we do is I take a history, I provide some accurate medical information, and we advise not using, and then we start drug testing, and then finally I also do a referral so that they can get help from a mental health counselor like Maria to support them through this process. Now next slide, please. There are some things that you may or may not be using or aware of that will help your patients through with the process of stopping a substance such as marijuana.
Hey, Jonathan.
Yes.
Just a real quick question. One of our audience members was asking if the urine drug tests, are generally covered, by insurance. This person was concerned that sometimes their sort of drug testing isn't covered.
Yeah, I have not had that problem. Obviously, there's so many different insurance companies, and that there may be certain ones that don't. I think Mass Health does, and the Blues do. Maria I know that they do this a lot more at PC Plus. Have you ever heard of any problems that they've mentioned? I have not.
I think it depends. Like if someone has like a high deductible plan, that they may have to pay the amount up into the fee until they reach the deductible. So I think it is dependent.
Yeah.
And in those situations, I think sometimes what we do is explore if it's it's too cost prohibitive, we'll look at another option like, are there at-home tests that you can purchase that would be better. I mean, it's not ideal. It's better to do it through the urine drug testing through the provider. But I think it's if they're like CLIA approved, I can't remember like what the acronym is.
Mm-hmm.
Those are like at-home tests that we can explore. And there's always like consultation if there's an issue, like through the MCPAP line and talking to the substance use consultants, if you're running into that problem.
Yeah, I haven't had that problem either, although I do know that the insurance companies have been concerned about some of the Suboxone clinics, sort of excessively ordering tests, and they're sort of charging a lot for some of those tests, and so I think they've tried to do some utilization management of that, but I haven't heard of anybody not covering it. So yeah, keep us posted and yeah, go right ahead.
So we with this patient that I had, and I've used this for other patients, there is a supplement that's over the counter called NAC, or N-acetylcysteine. What it is the mechanism of action is thought to be on glutamate, which is part of one of the neurotransmitters that is associated with cravings, and it probably works on the nucleus accumbens, and just as dopamine does, and that it's probably elevated in those people who are addicted. And what it can do is to reduce the cravings. That's what the key is. So it makes it easier to withdraw and stop using a substance. So this is the outline I do. It's over the counter. You take 1 pill the first day, 2 pills the second day, 3 pills the third, and 4 pills from the 4th day on. And I do it for about 8 weeks. And I see a patient every couple weeks and see how they're doing. That's when I do the urine samples as well. And then we can stop the medication if they've been free of using the substance for at least several weeks. But this is something that's been shown in placebo-controlled trials in adolescents. It's not as helpful in adults, I understand, but in adolescents, this has been shown to help reduce or help with reduction of use of cannabis. Next slide, please. Now, also, when you stop using cannabis, you might have withdrawal symptoms, and those can be very, very difficult. And there are different ways that you can help your patients with those withdrawal symptoms, depending upon what they are. And for example, with anorexia, you can use cyproheptadine or Periactin, which I think I've never used megasterol, but Periactin I have for patients with ADHD. The nausea, you can use Zofran or ondansetron. Sorry. Insomnia is very frequent if you suddenly stop using a substance like cannabis that you've been using regularly, and melatonin and hydroxyzine can be used for that. You might get headaches, and so you use appropriate pain medicine. And then for anxiety, which can occur also, hydroxyzine can be used as a PRN basis. Of course, I would avoid using benzodiazepines because of their addiction potential. Next slide, please. So a couple of things that often come through my mind are misunderstandings, and this was very brought home to me when we were using the PC Plus program. You don't need to have a patient who has a substance use disorder in order to refer to the PC Plus program or to call MCPAP for guidance. This is really key. Even if a patient comes to you and they say, they have anxiety, let's say, and they are using marijuana or cannabis just periodically, the PC Plus program is very happy to help them understand the difficulties, help them through that process of anxiety, and at the same time work on the substance use. So you don't have to be using it frequently in order to make that referral, and it's very helpful for patients who just have anxiety or depression or even significant sleep problems. The second roadblock is often when parents will come in, and I talk to the parents, I talk to the patient, and he just doesn't think it's a problem. He doesn't want to have anything to do with treatment. That what we can do is refer them, the parents, to the PC Plus program, and they can be given help in terms of how you can deal with your child who's using substances and what they can do to help them reduce and eliminate the use of substance. So I've had patients who have had successful treatment just by having the parents see the PC Plus program people. Next slide, please. So just to give follow-up on the patient that I saw a few months ago, he was motivated to stop.
Hey, Johnathan.
Yeah.
I'm sorry, just a couple of questions about PC Plus, and either you or Maria, I'm sure, can answer. One is, do they see patients in the transitional age bracket, 18 to 22? And also, do you have instructions for how to refer people to that program?
Yeah, we do see, we'll see them young adult age, so 18 to 22. Even I have some clients that are a little bit older. I'll go for at the end of the program. Out of the end of the slideshow, I'll go into a little more detail about how to make a referral.
Great.
So for our patient, he had a very good outcome. He stopped using. We started NAC because he was having cravings. He took NAC for about six weeks, I think. He started seeing Maria, actually. They worked on ways of dealing and coping with the other issues that he was dealing with. I saw him a few times more. We did urine tests. His first urine was positive, but actually after, I think it was a week and a half, his urines were negative, and subsequent urines have been negative. He's doing much better in school. His parents and he are quite happy and satisfied. And so now we just hope and that he'll continue to be on this path. And the advantage of being a PCP is that I will see him periodically. I will know what's happened. And he said that he felt very comfortable coming and seeing me because he knew me. And that really is one of the big advantages of being a primary care provider and providing this kind of care, is that it doesn't mean that you're going to some other institution. It doesn't mean you're going somewhere else. And it takes away some of that stigma and some of the hurdles of getting this kind of care. New paragraph. Oh. I was going to talk briefly about nicotine too. Nicotine is very common, as you all know. The most common forms of nicotine are vaping, cigarettes, Zyn, which are pouches of nicotine, and chewing tobacco. I wanted to make people aware of Zyn. I don't know how many people are, I'd really be interested in how many people are asking or seeing their adolescents using Zyn. Zyn is becoming much, much more popular. Now it is over the counter, of course, for people who are 21 and over. And it is now, I think, going to become the next vaping problem of our society. It is now on data number 2 in terms of nicotine products. It's overcome cigarettes. Zyn is owned by Philip Morris. They are marketing it with different types and flavors. It is marketed, and you look at their ads, they're young people. And if you look, they talk about how safe it is. And it is, if anybody remembers what vapes were like 10 years or so ago when they came out, it's the exact same game plan. And it's very concerning that this is happening, and I suspect it's going to go the same. It's not FDA monitored either. Next slide.
Okay, so I'll just turn it over, and we'll go. This is just a quick case example of an individual that I worked with who was wanting to stop their nicotine use. And again, we'll kind of go into a little briefly about some of the interventions. So this is a 16-year-old, Kristen, was referred for substance use counseling by her PCP because she wanted to stop using nicotine. She expressed significant motivation to stop her nicotine use, and she said that she was really struggling with the cravings. That was something, managing her cravings. So when I started working with her, I mean, obviously the initial treatment is, developing a rapport with her, exploring her motivation for wanting to stop. And what are the values and things that she is hoping for. And for this young woman, what she was really hoping for was to get back into playing sports. She hadn't played sports for a year or two because she had started vaping, And she really wanted to be able to try out for the basketball team in the fall, and I was working with her in the summertime. And so this, we really try to hold on to whatever this, negative motivation is. And I worked with her on looking at what her triggers were for the cravings, talked about how to manage them. I mean, a big trigger for a lot of young people in high school is the restrooms at school, because that's where other people are using. So we talked about whether she could use the single restroom, how she could use fidgets when she had that feeling. We talked about chewing gum or nicotine gum, through nicotine replacement therapy under the guidance of her PCP, providing her psychoeducation related to the neurobiology of addiction to normalize cravings, because a lot of times there's a lot of shame involved. And then, then we talked about nicotine replacement therapy. And through that, over time, over a brief period of time, she was started on those patches, and she felt more comfortable managing her cravings, was able to reduce them under the guidance of her PCP, and ultimately discontinued nicotine replacement therapy completely and discontinued treatment because she was improving. And John, you can briefly just describe, when you use the patches. I just have this slide here if you want to share a little bit.
Yeah, I won't get into the details. I don't want to take up too much time, but we can prescribe nicotine patches we can prescribe it for anybody. You can get it if you're 18 or above, but the problem is that, like this patient, if they're less than 18, you have to have a prescription. So what you can do is you can prescribe the patch. You depending, and this slide is available on the MCPAP website. So what I do is I'll prescribe a patch depending upon how much they're using. Next slide. And in addition to the patch, what you tell the patient is, if they have cravings, they can use 2 milligrams of lozenges. And what they do with the lozenges, it's called nicotine gum, but it's really better for a lozenge. So they can chew it a little bit, but they really put it under their between the gum and the cheek, and that way you don't get a spike of nicotine. It more is like this, so it helps them through that craving. Then I see them every few weeks, and will decrease, depending upon whether they're actually stopped or not, decrease the patch milligrams. So it starts at 21, then it's 14, and that was on the other slide. Next slide.
Hey, Johnathan, there's a question, or a couple questions just want to catch up on in the chat.
Sure.
One of the audience members, was saying that they had heard that the Zyn, is sort of that there are some nice things about it in the sense that it might be safer and but of course, a lot of it is marketing, and the audience member commented about that too. But I guess the point is that I wonder what your thoughts, and Maria as well, on sort of the harm reduction sort of perspective on things like vaping, things, we're even though we're always concerned about these kinds of things, I think a lot of people think of replacement treatments as another, sort of, not everyone is a big fan of them just because of similar kind of concerns about, sort of more of a pure, like a purity sort of perspective or attitude about these substances and things like that. But yeah, so how do you talk to patients about, these relative risks? Do you discourage them from vaping, even though there are, sort of some arguments to be made that from a harm reduction perspective, it's a lot better than combustion of tobacco, and inhaling that. But, I wonder if you can speak to that.
Sure. So I remember vaping, if you were going to compare vaping to combustible cigarettes, I guess, yes, that there are some advantages to vaping. But the point is that vaping is nicotine, and nicotine has many negative effects. It's one of the most addictive substances, actually, there is. And once you get addicted, then it also leads to further, in fact, data shows that vaping use increases your chances of smoking because it's actually cheaper, and you end up going down a road. So the idea is that using of these other substances that is nicotine, you use it in a controlled way. It is FDA regulated, and you know how much they're getting, and it's monitored so that you can have a point in the future where you're actually not going to be using a substance that we know is not good for you. The Zyn is 6 to 8 milligrams of nicotine, whereas the lozenges I mentioned are 2 milligrams, and they're increasing it. In other words, and this is what they did with other substances, that is Philip Morris is increasing the amount in the Zyns so that you become more and more dependent upon it. So I understand, and it does feel a little uncomfortable saying, okay, nicotine's bad for you. I'm going to give you some nicotine to help the problem, but it's in a controlled way. I think it's much, much safer.
Yeah, I think that's a great point. I think not everyone trusts, sort of the regulatory, sort of system, when it comes to, sort of the drug industry. But I do more than than sort of the vaping sort of industry, which is, like the Wild West, I think in a lot of ways. And so I think that could be sort of a good argument to make. But thank you.
Just a couple more things. I mean, the patches, you want to make sure you don't cut them. You change them every 2 to 3 weeks. And you have them come in and give you a report. I think just being there for them is helpful for them to wean from this substance. Next slide. I think there are other medicines that can be used, which I won't get into. That can be. It's rare for me to use Wellbutrin for this. I've done it once, but there are other. I don't think that this is a very common thing that I get into. And if you're really getting into a problem where you think you need to use this is really where the PC Plus program, I think, would be very valuable. I would then refer them, as I would any other medical problem that's kind of out of my league. I would refer them to somebody else, and they're very willing to see your patients there. Next slide.
And I'm being cognizant of the time. So I think the next example that I was just going to share was just highlighting, a young woman who was using alcohol, and mother had been finding bottles under her bed, like empty nips, empty alcohol bottles, had gone to the emergency room a couple of times related to alcohol poisoning, but the patient was not interested in treatment, and her mother was really concerned about the risks associated with Penny's alcohol use. So the PCP referred the mother for parent guidance. And, as clinicians through the PC Plus program or anyone who's providing parent guidance, we talk about behavioral management interventions, ways to try to engage the patient in therapy, developing written contracts, much as, what John was talking about earlier. There's a lot of, I can't get into the details today about that, but we do a lot. There's a lot that we can do to try to support parents in managing their child's substance use to the best we can. We talk about reducing access and minimizing risk. And then another thing is that we also offer virtual parent guidance, parent and caregiver guidance groups that are about 10 sessions, which we've gotten a lot of positive feedback on, because the parents, are able to talk in more detail about these interventions that they can try. Also receive, support from other peers. Again, there's so much shame and stigma related to a child, who's struggling with substance use. So these are just a variety of interventions that we are able to provide. And then again, I'll briefly go because again, I'm like, oh, we're really running out of time here. And in case there's any additional questions, so I just want to briefly go tools to use in your practice to address adolescent substance use. The S2BI, as John mentioned before, just using that as a screening tool. I don't know if you want to add anything, John. This is just an example of it, but is it mainly in the well visits that you're including the S2BI?
That's correct.
Okay.
Mm-hmm.
Yeah. So because this will help you identify who's using substances, and it also helps start the conversation. The MCPAP, as we mentioned earlier, consulting with MCPAP, calling the MCPAP regional team, asking for a substance use consultant. They're available Monday through Friday during business hours to address any substance use concerns, whether it's nicotine, alcohol, cannabis, opioids, you name it, or just, again, it can be related to specific guidance and tip sheets, or it can be just trying to figure out what resources are out there. The providers are very helpful from the Division of Addiction Medicine at Boston Children's Hospital. And then the website, again, you'll receive this, has a lot of the tip sheets, which a lot of what John was sharing is included on there. And so, that's available to you on the MCPAP website. And then I know John shared that, he's created workshops. I don't know if you want to speak to this briefly, John.
I'll briefly just say that if anybody's interested in educating as a group, I found it very rewarding to be able to set up a workshop for my patients, and where they come and talk, can hear about these sort of problems directly from us. And I'd be happy to talk to anybody who wants to set these up. I've been doing it for years now in my practice.
And so, yes, I'll get to the primary care plus program because I know that people were asking about it. So it's a virtual counseling and consultation program where our goal is to provide, to support primary care practices in delivering substance use care to adolescent and young adult patients in the medical home. So we focus on supporting the patient in the medical home. We provide virtual psychosocial care, so comprehensive biopsychosocial evaluation, individual counseling, group therapy, and parent caregiver guidance. We also provide referral and case coordination, and then consultation and training is available for primary care providers with the addiction medicine specialty program. So you can reach out to PC Plus, and our, the director of our program can assist you with, your team providing trainings, and so that you can develop more comfort to address some of these issues, as John has been able to do in his practice. So again, I think this is kind of repetitive, similar to the support. They provide a lot of support related to medication, psychopharm, drug testing, and more. Any patient who ages, who's using substances. I mean, we do take patients sometimes as young as 11 or 12 years old, but up to transitional age use. So 22, 23, 24, any patient who's screened positive or reported substance use in the last year. They don't need to believe that their substance use is problematic, or they don't even need to necessarily want to make a change. And it doesn't have to be the primary reason for seeking support, because we want to meet them where they are. If they're dealing with stress and anxiety, we want to be able to help them with that issue, and then we can integrate substance use education, prevention, and treatment when applicable.
Hey, Maria.
Oh, yep, I'm almost done.
Oh, no, I was just going to ask a quick question from the chat. One of the audience members was wondering if patients under the age of 18 can self-refer and have this kind of treatment confidentially under the mature minor law for tobacco or nicotine use disorder as opposed to other drugs. That was a question.
Yeah. So yes, they are able to receive under the mature minor. We're called the Primary Care Plus program because not like for the patients that are referred to us, some of their parents. I think if you're making this referral, you need to let us know ahead of time. If the parent isn't aware of their substance use, if they're not aware that they're using nicotine, they can be referred to us, and it's, that we're providing counseling. They'll just know that it's counseling. And so, yes, and we have every patient, even those under 18, have to sign a release for us to communicate with their caregivers in treatment. And, before the visit with the parent, we encourage like an evaluation with the patient, the teenager, and then we also encourage a evaluation with the parent when applicable and when appropriate. But the patient needs to sign a release of information for the parent for us to be able to meet with them.
Great.
So does that help? Okay.
Yeah, absolutely. Yeah.
So yeah, to make a referral to PC Plus, if you're a member of MCPAP, this number 617-730-6205 is where you can fax your referrals. If you need a referral form, I would email PCPlus at childrens.harvard.edu, and our coordinator can send you the referral, which looks like this. And you can also, I believe, I think they asked it for them to be faxed, but I believe they can also be emailed as well, if you have secure email.
What's the wait time nowadays for that program?
Right now, we several clinicians, we do have availability. So I think the main, it can be a week or two to just get in. I think our biggest stumbling block is contacting the patient and getting them to call us back. But we have several clinicians have openings in the afternoon, evening times as well, which are always the hardest to get. So yeah, right now we do not have a long wait.
That's great. That's good.
So yeah, we have openings. So I encourage you, if you're wanting to know more about the program, whether it's the trainings or knowing about making referrals, to give the PC Plus program a call or email, and we are happy to support you and assist you. And I believe that concludes the presentation. I don't know if we have any more time for questions. I can stop sharing also.
Thank you so much, Maria and Johnathan. And we got through all the questions. You ended exactly on time, which is really appreciated, I'm sure, by everybody. I just want to thank you so much for the excellent presentation. And thanks to the audience for attending. Reminder for next month, March 25th, anxiety disorders, Dr. Deepika Shalagram. And don't forget to fill out your survey. We really appreciate it. And don't forget to claim your CME credits if you want them. But thanks, everybody. Look forward to seeing you. And thanks to our speakers. Bye.
Bye. Thank you, everybody.
Bye.